Hello and welcome again to another edition of the Osteopathic Lyceum podcast. Want to take some time to speak about what could be called the lingua franca of osteopathy, or the common concepts or reporting standards, specifically with respect to diagnostic. Now, obviously, if you are an osteopathic practitioner, you're going to be aware of the Fryette model. Maybe it's not so obvious, I don't know. Maybe some other parts of the world use it less. However, the standard reporting, at least for the vertebral column, is based on the Fryette model. So what it's doing is it's attempting to report a diagnostic in all three cardinal planes. The word I'm looking for is cardinal. The three cardinal planes for the vertebral column. So you're going to see the sagittal plane, so you're either going to see an F or an E, flexion or extension. You're going to see the coronal plane, so it'll be SB, and so side bending, either right or left, and then you'll see R and right or left, so rotation. So it'll be and that's the transverse plane. So you'll see the sagittal plane, followed by the coronal plane, followed by the transverse plane, and that is your standard for describing the vertebral diagnostic. The second set of the standard for describing movement is based on those planes, but in other areas of the body, the names will change somewhat. And part of that is because the limbs especially will start to move in relation to the torso. So if you're moving in the coronal plane, you may hear abduction or adduction with respect to the arm or the leg or the lower limb, so the upper limb or the lower limb. You may hear internal external rotation. Now, that doesn't necessarily mean it's in the rotation isn't absolutely in the transverse plane. It's just with respect to a relative midline of the limb itself. You will hear flexion extension of some joints, so movement towards the front of the body is flexion, movement towards the back of the body is extension from anatomical neutral. So there's a lot of terms that have assumptions built into them. Right? One of the reasons that many in the osteopathic field seem to appreciate the field of biomechanics is because biomechanics is a lingua franca, or a standard language for describing movement. I would argue, and I think I've argued in the past, that biomechanics describes but doesn't predict. It doesn't necessarily tell you what to do about something, but it does describe how things are moving. So there's some use, there may be less use. Depends on who you are, how you want to argue about it. But at least it's a common language that can help with reporting. What I want to say, though, is that the language of reporting may not necessarily reflect properly the solutions for these observed issues. I want to specifically talk about this with respect to the Fryette model. The way that I've seen the Fryette model utilized with respect to moving from diagnostic to treatment is you simply attempt to do the opposite of what the diagnosis is. The diagnosis is movement preference, so something likes to flex, something likes to side bend left, and something likes to rotate right. Therefore, the answer is extend it, side bend it to the right, I think I said left, and then rotate it to the left. So just do the opposite. Or if something has dysfunction in one plane, then that side of the movement, those muscles are shortened and will not lengthen, therefore you need to lengthen them. It makes it harder because that's almost like an automatic algebraic fill-in. So you know one side of the equation, therefore you know the other side of the equation. And as far as clinical experience would dictate and observation would dictate, that's not necessarily the way it works. Sometimes something will side bend well to the left and side bend poorly to the right. So again, the automatic assumption is that the muscles on the left won't let go enough for you to be able to side bend to the right. Where what's really happening, if you observe it properly, is the right will do nothing. So it could be bony shape, it could be something else, but realistically, when you observe it, the left is functioning, the left is trying to do things, but the right will do nothing. If you use the standard language, the side bend left, right, that's the preference, therefore the answer is side bend it right and lengthen the left and shorten the right. So depending on the terms that you use, again, you're asking to algebraically autofill something. It doesn't allow you to generate the appropriate solution for the situation at hand. Because if the left is short, then yes, work on the left. That will allow the left to lengthen. That will allow the right to get into the position where now the left muscles aren't getting in the way. You could talk about, say, lumbar flexion. You're going to think about things like hip flexors, and you're going to think about the abdominal muscles. So if somebody can't extend particularly well, you're going to think, okay, I need to lengthen the front side, where what you might actually need to do is mobilize the back side. And it sounds like the same thing. But what I'm saying is you don't necessarily focus on the front. You actually go to the back and you work on the back and you work on that imparting movement to that area. So they side bend left well, they side bend right poorly. Sometimes you don't work on the left. You actually work on the right and impart movement to the right side. And because the left side isn't really in the way, the left side isn't really short, it just will function where the right side won't function. So talking about this, it is very evident that you end up needing to use a lot of words to try to describe it and try to show how an auto-algebraic fill-in approach, such as your standard Fryette reporting or your standard osteopathic reporting, where if something's having a problem flexing, you called it extended, it doesn't mean that it's extended. It means it won't flex, right? So just because a shoulder won't go all the way up doesn't mean it is extended, right? You can then argue, well, we didn't say that. We said it prefers extension. And maybe it does, maybe it doesn't. Maybe what's happening is it's restricted in flexion. So the reporting of motion preference has the opportunity to create the error of the autofill, like the algebraic autofill, as I've already said. You're like, okay, well, it goes left, so I'll just take it right. I'll lengthen the left so that it will go to the right. That may make it harder to observe where the issue is, because if you talk about it in a particular way, you tend to bind the thoughts that you can surround it with, especially because you're required to report it that way. When you bind the thoughts, you minimize the actual observation. So when you restrict, rather, the thoughts or the breadth or the width or the range of thoughts, then unfortunately you're accidentally restricting the solution set. It doesn't mean you don't want any language. It means there may be some benefit in partially reporting what it likes, but also reporting what it doesn't like. And then you can choose between, well, do I work on the right side? Do I work on the left side? What do I do? But if you, in my experience, learn with the Fryette model, then you just work on the side that it likes to go to. You lengthen that because that's the answer. Now, it doesn't mean everybody does that. It means I'm speaking from observation and experience. Again, circling back, even to try to explain something that I think is relatively straightforward, and if the opportunity was present to be in front of somebody and just show them, okay, you ask the person to bend to the left and they bend to the left, okay, and when they bend to the right, they don't do it well. And then it's like, okay, well, the left side's short, but then you look and the left side's doing everything it can, but the right side will do nothing, right? So that deal where the right side will do nothing, now you know you need to work on the right side because you observed it, as opposed to saying, well, the left side is restricted. It's like, well, they didn't even get far enough to the right to show you that the left was restricted. So words, repetitive, using words over and over again in the attempt to cognitively try to explain that if you have a particular form of reporting, it negates the opportunity to consider things in another light from another angle. So the osteopathic approach of reporting motion preference, especially when noting motion restriction, so you note the motion restriction, you just report the other side as the preference. You didn't necessarily check the preference, you just auto-filled it for diagnostic purposes because that's the reporting standard. It means you're thinking more about the idea and the reporting standard than you are observing the patient in the moment to identify the area to apply the solution most appropriately. Because people are more variable than one reporting standard will allow proper description of, right? So what's a way to try to approach this? That's what I was thinking. Sorry for stumbling. If you have a procedure, a step 1, a step 2, a step 3, and it's a relatively rigid procedure, there are definitely a lot of times that will work and it will work well. The issue is if the individual presenting is variable enough from the characteristics that will allow the procedure to work well, the procedure will no longer work for them. So if my reporting standard works for a lot of people, but it doesn't work for everybody, for those people it doesn't work for, I've automatically restricted the solution set by having the consistent reporting standard. I think consistency matters, so I don't want to argue against consistency. I just want to say that it is easy with the standard osteopathic diagnostic framework of reporting movement preference, essentially by saying the opposite of movement restriction, means that you're more likely to algebraically autofill your solution set. And for some it will work, and for others it won't. So it's more an argument to try to say, be careful, don't stay stuck in the standard reporting system. The standard reporting system seems to, in my observation, both as a practitioner and an instructor, a teacher, an educator across time, the standard discussion around osteopathic diagnostics seems to make it harder for people to observe what's right in front of them and work on what's right in front of them. It seems to promote working on the idea of the reporting standard as opposed to the person. It has benefit. It provides some common language to start a discussion and have some reporting. It doesn't necessarily do a great job teaching what to do in a given moment. It's not necessarily good for communicating what one would do when presented with these things. Clinically and experientially, when people present a case to you with words and they say, well, what would you do? Usually the answer for more experienced practitioners is, I'm not 100% sure unless I see them. But based on what you're saying, maybe you consider this. Very common discussion, very common set of words, sentences, things like that. Whereas if you rely on the standard reporting system and the standard models of treatment, then you're like, oh, well, you do this. And if that doesn't work, well, then you do this. And if that doesn't work, well, then you do this, right? What I will say is if you start from, you must tune into the patient, you must search for what they respond well to, as long as you know what the response you're hoping for is, you'll figure the solution out as you go, or you'll do a really good job, even if you miss it a little bit. The standard reporting approach, the sagittal plane followed by coronal plane followed by transverse plane, or this general biomechanical reporting of limbs in relation to the anatomical position or anatomical neutral, that generates a situation where it can seem like you can provide an answer for what somebody should do, even if you haven't observed the patient, which unfortunately isn't the case. So it becomes model over reality, or idea as the most important thing, as opposed to the observed, experienced reality in the moment, solving for that patient. So you want to be careful with the standard osteopathic reporting system, diagnostic reporting model, because it seems to pull you away from the patient, in my experience, as opposed to allow you to observe the patient. If you are only looking for what isn't moving, right, you seem to be able to accurately respond to the patient in the moment. Whereas if you're saying, okay, do they like left or do they like right? If they like left, then I lengthen left, right? Because they don't like right, they won't go to the right. That means the left is short. It doesn't actually seem to work that way. It's a little bit more variable than that. So if I were to make a suggestion to most osteopathic practitioners or most hands-on practitioners, it would be find out where it doesn't move and keep that your idea. Because if your idea is where does it not move, or your question is where does it not move, you find that, and then you can generate solutions for that, as opposed to a predetermined procedural set of solutions, which if they don't match the patient properly, won't work. Whereas you could search for what the patient responds to appropriately, as long as the goal and the direction is known, you can figure that out, as opposed to applying a predetermined idea to a person who may not fit that predetermined idea. So lots of rambling to try to get to that point. Whether it is a treatment approach, a technique, or the standard reporting system, the diagnostic reporting system of osteopathy, they tend to take you away from paying attention to the patient. They tend to put you in a position cognitively where what you're going to do is try to apply a predetermined idea to a person in the moment who it may not work for, And if you're not paying attention to that, you'll miss it. You'll miss the opportunity to solve with the person in front of you. It's probably the best way to say it. So thanks for listening to the ramble. Thanks for listening to the repetition. Hopefully you learned something, and we'll talk again soon.